Welcome to part of your cardiac lecture. So first I want to tell you that I am not a cardiac nurse. I have never been a cardiac nurse. I have been a trauma ICU nurse. I've been a progressive care nurse, and I've been a med-surg nurse, along with home health, management, blah, 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 lots of other things. Not cardiac, not my specialty. But I will tell you as a nurse in general, I put cardiac rhythms in two different categories: life-sustaining versus not life-sustaining. Some rhythms are life-sustaining and we don't need to worry about them. They're just irregular rhythms. And some rhythms are not life-sustaining and we need to get in there and get going right away with them. So we're going to work with a few rhythms today. So what rhythm are they in and what do you actually do about it? So let's talk about life-sustaining rhythms first. Life-sustaining is when it is effectively pumping blood throughout the body, the organs, everything is getting enough oxygen so that it can work efficiently. Now, it may not be working the best that it could ever work, but it's working efficiently. So when we're looking at the heart, we've got the P wave, which the P wave is the depolarization of or electrical current of the atria contracting. So the P wave is those top two chambers of your heart contracting. The QRS wave, usually that nice big wave, that's your ventricles. And so it's the depolarization of the ventricles or the electrical contraction. So what we have to understand is what an ECG shows us is the electrical current going through the heart. And so the very last wave is the T wave, which is the kind of that recovery or reboot period. So kind of our heart has to kind of reboot so that it can pump. All right, and this happens over and over and over again, approximately 60 times a minute, so or more, depending on how nervous or fast you're going. If the pump is going too fast, it doesn't have enough fill time. So we really want to keep it going slow enough so that the pump can fill well. But if the pump is going too slow, it isn't efficient enough to maintain the organs and to keep everything perfusing. So it's kind of like Goldilocks and the Three Bears. It needs to be just right. The pump, also if the pump is too weak or it is damaged, it will lengthen or widen out these waves. And so that's where those measurements start coming in and becoming really important. As these waves start stretching out and becoming longer, that means the heart is taking longer to pump. And that shows us that there's something wrong with the heart, all right? And so that's why we use this to know if there's damage in the muscle or the tissue. So after you look at a rhythm, what each one of them means is the time. And we're starting to figure out then what do we do next. So it's really important that we understand the anatomy of the heart and how the blood flows through it. So blood comes into the heart from the body, low oxygenated in the right atria and goes into that right ventricle. That right ventricle is smallish because it's going to pump into the lungs. And we don't want a ton of pressure going into the lungs. We want low pressure into the lungs. The lungs are very sensitive. They cannot handle a ton of pressure. So that's why we get into like pulmonary hypertension and we realize how bad it is, because we want the lungs to have a good amount of pressure, but not too much that it's going to actually damage them. Once the blood is oxygenated, it comes back into the left atria and then goes into the left ventricle. And then our left ventricle squeezes nice and tight and it pushes it out through the aorta. The left ventricle is, however, very big compared to the right ventricle because the left pushes blood all the way down to our toes and back up again. So it really is the muscle of the pump. And it's important for us to understand how the blood is flowing through the heart because different illnesses can be caused by certain areas of the heart being not as effective. So let's talk about its time to assess. So this is what I like to do. This is what I go through when I'm working with a patient with cardiac issues. Is it real? Is it regular? And is it effective? So let's start with, is the rhythm real? Is the patient, because sometimes you can like see a patient will be like in VTAC, right? And we'll talk about what that is here in a second, but they'll be in VTAC. And so you run into the room and the patient is just sitting there tapping on their V lead because he wanted you to come into his room sooner because he wanted an ice cream sandwich or whatever, right? So again, it's not a real rhythm. Or maybe they call you and say, hey, you've got a patient in asystole. You run into that room and the patient's in the shower and they have their telebox off. So again, first things I do is I open my eyes as I walk into a room. I may be walking into that room quite quickly, but I'm going to walk into that room and I'm going to open my eyes, because oftentimes they're not actually in those bad rhythms. They're doing something, they're coughing, they're moving, and the rhythm, it's just picking up the movement or the electrical current other ways. Then I start looking, is it regular? So when we start looking, there's calipers, there's different ways to measure rhythms, but you can kind of look and see, is that rhythm regular? A pump should be working in a regular pattern so that it can do its job effectively. So then that moves us to the next one. Is it effective? Is it effective? Lots of people walk around with heart problems all the time, and they're not, passing out or dying on the street. They just have a cardiomegaly, or they have a little CHF, or they have AFib or something like that. And so not everyone has a perfect regular rhythm. And so it's really important for us to make sure, is it effective? So how are we going to tell if it's effective? Well, the color of their skin, right? If they're nice and pink, that shows us they've got good color. It shows that it's effective. If they have a pulse, it's showing that it's ineffective. Now, if I feel for the pulse and it's weak, very barely palpable and thready, which means just fast and hard to feel, then that makes that maybe they're not really effective. Or if I go in the room and they have a pulse but they're unconscious, that's telling me that something else is going on. And that is going to determine some of my level of urgency, right? If I walk in the room and they're up taking a shower, my level of urgency just goes down. If I walk in the room and they're unconscious in the bed, level of urgency goes up. So let's look at this rhythm. What is this one? Life-sustaining or not? Is it regular? Let's start with, is it real? Well, we're going to say we can't assess the patient, but we're going to say, yep, this is a real rhythm. Is it regular? Yes, it looks very regular. And is it effective? Well, if I want to know if it's effective, I've got to check a pulse of a patient. But we're going to say this is effective. This is normal sinus rhythm. This is what you and I and everyone wants to be, right? Between 60 to 80, nice and relaxed, good fill time. And you can see the little P wave, the high spike of the QRS, and then that T wave of the reboot. And this is what everybody's ECG should look like. It's what we want it to look like. What would tell me if this was inaccurate? If I come in and my patient has this rhythm, but they're unconscious on the floor, that means something else is going on. So be very careful. While yes, a cardiac rhythm is really important, it cannot tell you the whole story and it can't give you the whole picture. There are lots of pieces. This is one piece to the puzzle. Is this life-sustaining or not? So is it real? So yes, we're going to say our patient looks like this is a real rhythm. Is it regular? Well, it's not really regular. I guess it's regular flat if you want to go with that. And is it effective? The patient would be unconscious on the floor, not breathing. This is asystole. This means they have no rhythm. So really interesting with this one, and I know everybody says on Grey's Anatomy, they shock these people. You cannot shock asystole. If you came into a room and you saw a patient with this kind of rhythm and they genuinely looked at it, so they were not pink in the cheeks, they were gray and ashen, not breathing, not responsive, no palpable pulses, you would want to start CPR immediately. Pull your code light, shout for help, whatever it is that your facility has at their system. But you'd want to start CPR immediately. Really important with CPR, get that backboard under you. Giving chest compressions on a bed. Beds are squishy, chests are squishy. You're not going to get that full compression and beat. Asystole, we do not shock. The purpose of shocking a rhythm is to reboot the rhythm. You cannot reboot a rhythm that there is not an existing rhythm. So this would be a person that we would start our ACLS protocols. We'd probably give some epi. We would keep doing chest compressions, and we would try to figure out why they're in asystole in the first place. So this is not a life-sustaining rhythm. What about this rhythm? So let's go with, is it real? Yep, we're going to say it's real. Our patient looks real. Is it regular? Well, just by looking at it, I can see there's some big blockage, there's some wide areas. It's definitely not looking like a regular rhythm. Is it effective? Well, okay, so if my patient is breathing or not and talking to me and all that kind of stuff, okay, we're okay. but it's definitely not a normal rhythm. So when I look at it, what's not normal about it? Well, my P waves, I can't tell them where they are, right? Because it looks like there's P's and T's all kind of in between the QRSs, and the QRSs are definitely not in a regular, nice pattern. This is atrial fibrillation. So this means the atria are just kind of quivering on top. And you can see your atria, if you were to count them, are probably beating between 100 and 120 times a minute in this strip. And so definitely not a regular rhythm. We're not getting effective fill time. We would want to make sure that we're going in and assessing this patient. Now, if this was new onset AFib, that would change how we're going to care for our patient. We'd maybe want to have to call the doctor. We'd want to have to see what's going on. The only interesting thing with AFib is any rhythm can be an okay rhythm as long as somebody's walking, talking, and doing fine with it. So AFib, people can be walking, talking, doing fine with it, but if it's new onset, they may be lightheaded, dizzy, pale, flushed, they may be symptomatic. If they are symptomatic with atrial fibrillation, it puts it up in that urgency list. It puts it up in the concern. We have to figure out what's going on, and we have to prioritize that. So think about that. Are they having symptoms? Asymptomatic versus symptoms. Asymptomatic, no symptoms, they're fine, they're walking, talking, joking with you, doing whatever, playing bingo, who knows. But somebody who is symptomatic needs to be dealt with a lot quicker. So AFib, we have problems because the atria are quivering. P waves are not correct. There's too many. The heart ventricles don't know when exactly to pump, and so that can cause a problem. The other thing with AFib is if the blood isn't moving and flowing, think about what also is in that blood. Platelets, coagulants. When the blood pools, blood clots. And so when we start having atria that are quivering and not pumping effectively, that means now that we're getting clots in the atria, which then puts our patients at really high risk of having strokes, because that's where it pumps the blood to, is it goes straight to the brain. So a lot of problems with strokes for patients that have AFib, and that's why we like to keep it controlled. That's also why we start giving them anticoagulants if somebody has AFib, is to help prevent those strokes. So is this a life-sustaining or not rhythm? So looking at it, is it real? Well, you go in, your patient's not really looking at you, okay, so it's probably real. Is it regular? That's definitely not a regular rhythm. And then is it effective? So this would not be an effective rhythm. This would not be pumping, right? There's no P wave for the atria to be depolarizing. Our QRS wave is really wide, meaning that it is taking a long time for that electrical current to go through the heart. This is causing a lot of problems. This is VTach, or ventricular tachycardia. So it's those QRS waves that are it's just pumping. And our who knows what the atria are doing, it's probably buried somewhere in the rhythm. But typically a person with this rhythm would not be talking to you, they would not be responding to you, you would not feel a pulse on them, because the ventricles are just not doing their job, they're not filling, they're not pumping, and lots of problems. I have had one patient in my lifetime that was talking to me during a VTach episode, and so, you know, I can teach you black and white, and then the world is going to throw some weird form of gray at you. It just happens. But this is not a life-sustaining rhythm. If this were a real rhythm and not somebody just tapping on their telemetry unit in the V-lead, this would be a person that's in a lot of trouble and would need help very, very quickly. So let's talk about heart block, because heart blocks get kind of wonky. There is first degree, second degree, and then third degree. So first degree heart block is where that P wave gets kind of stretched out, and there's more time between it. Notice there's the P waves kind of way out to the side, and then there's a long period of time before it, and then the QRS goes. So that length of time means that there's too much fill time going in there, and the electrical current's not going through quite effectively. And so that becomes a problem. Now, can somebody live and be walking and talking on first degree heart block? Yep, they sure can. We're going to give medications to try and help them, but very often first degree heart block is just something that they're going to have to live with. Then you get into the second degree block, and I love that's Winky block or Mobitz 1, and they got Mobitz 2, and we just start, and that's when we start dropping those P waves and they start like getting buried. Heart block is an interesting thing where it's the top of the heart and the bottom of the heart, so the atria and the ventricles, the nodes are no longer talking to each other. And so as the block becomes worse, we get into third degree heart block where they're completely not talking to each other, right? So one, you had the atria fill and then the ventricles fill, and then the atria fill and the ventricles fill, and it goes back and forth with that rhythm. But when there's a block between that, the electrical current doesn't talk to each other anymore. And so once we get into third degree heart block, we now are no longer at a life-sustaining rhythm because they're not talking to each other at all. The ventricle's doing whatever it wants. The atria are doing whatever it wants. And so that fill time, it'd be like trying to start your car without the gears being all in the right spots, and it would just grind it all together, and so not be accurate or not be helpful at all. So with somebody with heart block, we want to get them in. These are people that are going to get pacers. They might get medications to help. And so we're going to be helping these people out with a lot of cardiac help. So let's talk about, we talked the blood flow through the heart. Now let's talk about the blood flow to the heart. Blood flow through the heart puts clots in the brain or the lungs. So if you've got the atria that are quivering and the clots are there, that's going to put it up in the brain. If you've got a DVT that has traveled up and gets into the heart, it's going to put the clot into the lung. But what happens when the clots get outside the heart and now get into the vascular system of the heart? So we talked a little bit in class or in lab at some point about the widowmaker, and that's the left main coronary artery, because think about where the left main coronary artery goes. Why do you think it's called the widowmaker? Think where the left is. Which ventricle is it feeding? It's feeding that left ventricle, that big muscle that we need to be accurate, and we need to be pumping into it because it pumps the blood all the way to our toes. And so it's really, really important that that one stay open. The other ones are really important as well, right? We really don't want any damage coming to our heart because we want the blood flow to the heart and through the heart. And so it's really important if that happens that we're taking care of it. But think about, what are we going to do if a person has a block in this left main coronary artery? We are going to have to start CPR on them, right? Because this heart is going to completely fail. Why do we do CPR? We do CPR because we act like the pump. We restore flow. Until we can get somebody there or get them to the cath lab, we restore the flow with our hands on their sternum, compressing and pushing down until we get them to where they need to be. So what does it look like when somebody's having a heart attack or myocardial infarction? So here's a 12-lead ECG, which you'll hear EKG, ECG. I don't think it matters, but technically it's ECG, electrocardiogram. The purpose of a 12-lead ECG is that it looks through the heart in 12 different planes, and it can see the area of the heart is having trouble conducting the current through. So they can tell, people who are paid a lot more money than I am and really good at cardiac stuff, can tell by looking in the ECG exactly where damaged tissue is. When someone is having a heart attack, we have this thing we call tombstoning. Now, tombstoning is very, very bad. It means that there's ST elevation. So you can see by where I put the arrows that there's elevation in those areas, and that's ST elevation. And that means we're having an active heart attack currently. You can, I think, have some from scar tissue and stuff, but when we're having one currently, you'll see ST elevation. ST elevation is never good. So what do we do if somebody's having an active heart attack? We call it Mona. And I don't know about you guys, it's not Mona Lisa, right? We gotta do something else. We're not doing a painting for them. Our goal is the same for patients that are having a heart attack, right? We want to restore flow. So we can't restore it without some help from Mona, which is morphine, oxygen, nitro, aspirin. Morphine controls pain, but it also helps with the air hunger that happens with a heart attack. You'll see people that grab their chest and they say they can't breathe, all right? But it also helps with relaxing the vessels, because to restore flow, we've got to get those vessels opened, and we have to get oxygen to the tissue. So obviously we're going to give them some oxygen. We just want to put them on some to keep that like almost hyper oxygenate them, so that whatever oxygen is getting through, it's getting to the tissue as much as possible. Nitro is nitroglycerin. It's usually given under the tongue. You can give 1 tablet every 5 minutes, and it will, so over like 15 minutes or so, you'll give 3 tablets depending on if they're having any relief. We also use nitro for angina, which is the pain that people get in chest pain. And sometimes that's from just vascular spasms that can happen. And so if we give them nitro, it helps dilate those vessels open to help control the angina. And then we give them aspirin. And aspirin, we want them to chew it. We want them to chew it because we want it to absorb faster. Our mouth can start absorbing things. And so it's really important that they chew it for quicker absorption. What's the purpose of aspirin? It's not for pain, it's to prevent the platelets from sticking. Because there's already a clot in there, the last thing we need to do is have the platelets keep sticking and make the clot bigger and make us have a harder time. You and I are not going to fix somebody having a heart attack. We have to get them to a hospital. So you're going to be calling 911, you're going to be getting help. They're going to probably go in for a heart catheterization, where they go up the groin and they go into the heart and they put in either a stent or they try and remove the clot. So this can become an emergent procedure depending on where the heart attack is happening in the heart. But just know, this would increase your level of urgency. This would make this a very quick and fast process. All right, so let's try it. So here's our patient, right? Here's his rhythm. So look at him, look at the rhythm. First of all, does it look real? Well, he's not swinging at anybody. He's not restless. He's not moving. So I would say it's a pretty accurate rhythm. The other thing that can cause rhythms to look funky is what we call artifact. And that comes with people like when they're moving around. So sometimes rhythms won't be accurate if they're walking around, or if they're wrestling with a tech or something like that. So I would say, yes, this is a real rhythm. Is it regular? It doesn't look very regular. There's definitely some interesting stuff happening in there. And it doesn't look like that nice normal sinus that we usually see. Is it effective? I would say yes. He's got some color in his cheeks. He's definitely not a tan gentleman, but he's got some pink in his cheeks. He's looking at us, so he seems responsive. So my urgency level goes down while I figure out what this rhythm is. Where are the P waves? Where are the T waves? Okay, so we're looking at that. I don't really see, I see a lot of P waves and either no T waves, or P waves and T waves all mixed together, and you can't really tell. So that's going to tell me that we're in AFib. If those waves looked like a saw, that's called a flutter. And so it's just another type of AFib, but it's just a flutter, and it looks more like a saw tooth where the P waves should be. But this is definitely an AFib. So what would I want to do next? Well, I'd want to make sure, is this a guy, does he have a history of AFib? Is this a new onset? Is he having symptoms? Is he not having symptoms? Is he on any medications? Like, is he on Pacerone and he's due for his morning dose? What's going on? Does he have cardiac already on his case? Or do I need to call cardiac? Or do I need to call his regular doctor or provider to get cardiac on board? So those are kind of some things that I'm thinking about as I'm working with patients and working with their different needs and unique aspects. I hope this kind of helps you break down the different cardiac rhythms, but really think about, is it life-sustaining? Is it not life-sustaining? If it's not a life-sustaining rhythm, your level of urgency skyrockets. It becomes very different than if you're like, hey, they're life-sustaining, they're doing okay, they're not having symptoms, but I do need to go get them looked at, and what am I going to anticipate for my orders from my doctor or my providers? Hope this helps you guys. Let me know if you have any questions.